In the last webinar, I had indicated that a friend of mine wrote a paper on nutritional support of a hospitalized patient, and the very first sentence said, "Food is love." And I believe that. There's no indication for an animal to be malnourished while in the hospital. The first thing I'd like to do in any critical patient is nutritional assessment, and that includes taking a feeding and appetite history. What is that patient been eating? Has the appetite been increased or decreased? For example, a patient can be losing weight if they have hyperthyroidism or diabetes mellitus, and at the same time be having a ravenous appetite, versus an animal that has a decreased appetite and is losing weight. Can that patient be suffering from a condition like kidney failure, like heart disease, like cancer, for example? And then some patients will have a perceived weight gain from their family members. An animal can lose a significant amount of muscle mass despite looking like they have a pot-bellied appearance and have weight loss in the moment. And so if you look at their actual numbers on a scale, they've lost weight, but they physically look bigger, either because of a condition that has caused ascites or cranial organomegaly, or has a large mass in the abdomen or something like this. This photograph is a picture of the dorsal spinous processes of a dog that had end-stage heart disease and had actually a very, very full pot-bellied appearance because of more than 8 liters of fluid in his abdomen, but had lost pretty much all of its body fat stores. So all of the bony prominences were visible. In patients that are losing weight, do they have preference for certain food types? Have they become more finicky and will only eat maybe table scraps or canned food or soft food versus dry kibble? This is different than a patient then will eat anything. And so if there's a finicky preference that was not usual for that patient, then I start looking at their dentition. Do they have such horrible dental calculus and dental disease that it just physically hurts them to eat hard food? And so that may be something as simple as an extraction of one or multiple teeth and a dental cleaning. I say simple. For those of you who do that, I admire you tremendously, because that's one of the things that I never really learned in vet school, and being emergency and critical care has not become something that I'm comfortable with. And so looking at the nutritional assessment, too, look at the body condition score. This is a very fat cat that was sedated. He weighed 36 pounds. Look at evidence of muscle atrophy, pleural effusion. Are there muffled lung sounds? Is there ascites? Or is there poor dentition or gingivitis? Enteral nutrition is very, very important because the enterocyte will undergo atrophy within 24 to 48 hours without lack of stimulus and nutrients within the lumen of the stomach and the small intestine. And this can increase patient morbidity and mortality, and that's very important. And so when clients are being approached with, I need to place a feeding tube, I don't really ask permission. You know, it's like, this is something that we need to do to get your patient, your pet, out of the hospital sooner so they don't get sicker. The second little bullet point here discusses a study that was done in puppies with parvoviral enteritis that actually had tracheal feeding of an amino acid solution through vomiting. So these puppies were being fed through a nasoesophageal and nasogastric tube, and then although they were still vomiting, these patients had a decrease in the time to recovery. And so it's not going to necessarily change the difference and make the difference between life and death in the most critical patients, although I do argue as a proponent for that. It can decrease patient morbidity, and even if you weigh the cost of the feeding tube and the radiograph to check tube placement, I think that far outweighs the cost of several days of hospitalization. The effects of malnutrition, particularly in a critical patient, is basically impaired wound healing and enterocyte atrophy, which can translate to an increased risk of bacterial translocation, and those patients could potentially become septic. This certainly will increase their morbidity and length of hospital stay, as well as potential for contributing to patient mortality. So I'm a pretty steep proponent of placing feeding tubes early on in these patients. The length of time that I wait during hospitalization is very, very commensurate with the length of time that the patient has been inappetent before they finally get to me. So if it's been a day, I might give them a shot in the hospital with an appetite stimulant or a variety of foods that are more palatable, for example, or anti-nausea medication or something like that. But if it's been several days, particularly if it's a cat, it's been more than 72 hours, I'll place the feeding tube as soon as I admit them into the hospital because I think it's that important. And so for patients that are not vomiting, appetite stimulants can work very, very well. Other things that we can try is warming the food. No one likes to eat really cold things right out of the refrigerator unless it's ice cream, and so or a cold drink on a hot summer day. But we warm the food. Always check it for hot spots because if the patient has a bad experience and gets a really, really hot something in its mouth, it may be further adverse to eating. So check it like you would, checking food for a baby. Add spices to the food, make it more palatable. Try and eat baby food that doesn't have any onion or garlic powder. Adding different types of yogurt, provided they don't contain xylitol or cottage cheese. Intravenous diazepam can work pretty well in some cases, and the cats wake up and suddenly start eating. So have food available in that moment if they choose to start eating. And cyproheptadine can work very well in some patients, although it doesn't necessarily work immediately. My preference is now using mirtazapine. I like mirtazapine as an appetite stimulant. It works very, very well in cats. It used to be thought to give every 3 days, and I never really understood if I gave it on the third day or the fourth day. So I actually give 3.75 milligrams per cat once a day, and that has worked pretty well. Force feeding is very, very stressful for both the patient as well as the caretaker in many cases. And so many times we wear a portion of what we're trying to feed, and as a result, it's difficult to meet the patient's caloric needs. And some patients will become so adverse to being fed and being force-fed that they can either aspirate food, choke on it, aspirate food down into their lungs, or will develop a stress-induced nausea and vomiting and then further decrease in their tendency to eat. And so this dog on the bottom had been force-fed for many days, and it got to the point where the owner approached the dog to force feed it, and the dog would immediately start to drool and then would vomit. And that is totally counterintuitive and goes against what we're trying to do. And so I think it's much easier to place a feeding tube, and then the choice of feeding tube is dependent on how bad the patient is critically, in some cases, how bad the patient is temperamentally, what the primary problem is, and how long we think it's going to take to turn that patient around, as well as thinking about the portion of the gastrointestinal tract that is either functional or non-functional when we're considering what to place and when to place them. I think the feeding tube is indicated in any patient that's been anorexic or hyporexic.